essentially patients had to be in essentially the third line or beyond. They had the eligibility included patients who had had prior trastuzumab, pertuzumab, and TDM1, and that's mostly where I would use it in the clinic. I would not save it for 8th or 9th line therapy. I think you want to move it up in therapy because of these potential benefits, including the survival benefit. And again, the benefit was not limited to patients with brain metastases. It was seen in the overall population of patients, half of whom did not have brain metastases at baseline. As with all treatments, there can be a learning curve in terms of managing the toxicity profile. Fortunately, the toxicity profile here was quite manageable, and much of the toxicity stemmed from known capecitabine toxicities, which I think oncologists are very well equipped to handle, having used capecitabine quite frequently in the past. Trastuzumab, again, is something that most patients will have been exposed to already by the time they're ready for the HER2CLIMB regimen. And then with tucatinib, there can be some diarrhea. It's possible to have rash, but these are less common than with some of the other tyrosine kinase inhibitors, which target EGFR more strongly. And finally, there can be some increases in liver function blood tests that we monitor obviously very carefully. But overall, the regimen, I think, is something that is manageable from a toxicity standpoint. Patients can have excellent quality of life while receiving this regimen. In fact, within the HER2CLIMB trial, there's a quality of life sub-study, which is being analyzed, and I think will provide further detail on how this regimen affects quality of life in patients treated with a triplet